Very lucky to have Peter Huckfeldt to deliver the next segment about working with the carrier and outpatient files. He is a health economist and a professor here in the Division of Health Policy and Management, and has been thinking about these types of payment systems for a long time. So it's been great to have him as we have delved into this encounter data. So I'll let you take it away, Peter.
Thanks, Steph. I'll be talking about the carrier and outpatient encounter files, and the kind of basis for this segment is some work I've been doing with Stephanie and Becky Vick, looking at the carrier and outpatient encounter data. And so the key question that I'll be talking about today is how well do the carrier and outpatient encounter data capture the healthcare use of Medicare Advantage enrollees. And we're going to be doing this by comparing healthcare use that you capture in the encounter data compared to another data source, HEDIS data, which I'll describe in more detail in a little bit. And we're focusing on two different measures. So we're looking at how well encounter data captures ambulatory outpatient visits, and then also emergency department visits. And so the goal today is to just describe how the visit rates that we observe in the encounter data versus the HEDIS data, and how they differ over time, how they differ using different approaches to define these types of visits, and also how they vary across insurers. And so that's kind of the research question we're tackling. But the other second goal is to just provide some examples of analytics decisions that we made, and hopefully this will help guide your own analysis of encounter data. So just as a starting point and to provide some motivation, which is, I think, similar motivation for this entire workshop today, but just to provide a point of departure, as I'm sure you all know, enrollment in Medicare Advantage is growing rapidly. So in 2022, I think it's 42%. And so, there's increasing interest in how Medicare Advantage plans provide healthcare. And really, I think it's a critical policy issue to understand the effects of MA enrollment on healthcare use and healthcare quality. But to tackle this research question, we need to have data on healthcare use that is accurate for Medicare Advantage enrollees as well as traditional Medicare enrollees. And so, today we're talking about the encounter data, and there have been concerns raised about the completeness of the encounter data, particularly the early data from 2015. So this is, the concerns have come from various sources. So MedPAC has put out some reports on this, and Steph earlier mentioned the some of Jia Zheng's work that's been published recently, and so there's a sense that particularly early on the data was quite incomplete, and that it also varied quite a bit across different insurers and different contracts. So some Medicare Advantage plans and contracts submitted more complete encounter data than other plans and contracts. So what I'm going to be discussing today is some analysis that we have done that kind of furthers this earlier work on the completeness of Medicare Advantage encounter data, looking through 2018. So a key issue when you're trying to assess the completeness of encounter data is that you need a comparison data source that can serve as like a gold standard, right? And so what we're using as our quote unquote gold standard data source is the healthcare effectiveness data and information set. So these are data that Medicare Advantage plans must submit to CMS that are used to calculate performance on different measures of quality and healthcare use and efficiency. And so we're focusing on these two measures that are submitted through HEDIS. One is the rate of ambulatory outpatient visits per 1,000 member months, and the second measure are emergency department visits per 1,000 member months. Now, one question is why did I put gold standard on this slide in quotations? And the reason is that the HEDIS data are not exactly a gold standard. So they're not, so MedPAC discussed this in a 2019 report. The HEDIS data are not really an external data source in the sense that they're not coming from outside of the Medicare Advantage plan. They're coming from the plan, and that's being sent to CMS. And so it's not an external data source, and it's not extensively validated. And so really what it is, the HEDIS data are comprised is the Medicare Advantage plan summary of its own encounter data. So its own summary of its own encounter data using these NCQA HEDIS specifications. And so if you're comparing the HEDIS data to the Medicare Advantage data, what you're really capturing is the consistency of the measures that the plan is submitting through HEDIS with the encounter data that the plan is submitting to CMS. One moment. So it's not really a perfect gold standard, but there isn't really another readily available gold standard to use. So this is what we use in this analysis. A second issue with the HEDIS data is that there is person-level HEDIS data that you can obtain from CMS, but we didn't have access to the person-level data, especially for the later years. And so what we're using is the contract-level HEDIS measures. And so as a result, we can't identify if the same Medicare Advantage enrollee had the same number of visits in both data sets. Instead, what we're doing is looking at the concordance of the contract year level of visit rates across the two data sources. So essentially what we're saying, what are the visit rates from a given Humana plan in the encounter data compared to the HEDIS data? So the key task in this analysis is to recreate the contract level HEDIS measures using the encounter data. And so that's what I'm going to describe in some detail now. So to recreate these HEDIS visit rates, what data do we need? So we need 4 different data sets. The first is we need the master beneficiary summary file, the Part C segment. The second is the carrier encounter file. The third data set is the outpatient encounter file. And then we need to have the detailed HEDIS specifications for each of these measures. The outpatient visits and ED visits. So I'm going to walk through the 3 data sets here. The first data set that we used was the master beneficiary summary files. Excuse me. So we use these data from 2015 to 2018. And so just to review, the NBSF is a person level file in each year, and it includes lots of information. But among other information, it indicates someone's Medicare enrollment in each month of the year. And so the key fields that we used for this analysis were the contract ID for each month for Medicare Advantage enrollees. So these the variable name that you can find in the encounter data documentation is on this slide. And we use these fields to calculate both the numerator and the denominator. So first, we needed to know, we needed to be able to link outpatient and ED visits to specific Medicare Advantage contracts. So, if we see a visit for a given beneficiary in the encounter data, and then we know from the NBSF which contract that beneficiary was in a given month, then we're able to construct this numerator for the number of outpatient or ED visits to that contract in a given month. And then we also use these data to count the number of member months for each MA contract. So this is the denominator for the rate we're going to calculate. Okay. So the second file that we used was the carrier encounter file. And so just to review, the carrier file includes professional encounters received by Medicare Advantage enrollees. And so we needed these data because the HEDIS specifications for both the outpatient and ED visit rates, excuse me, are identified in part using the professional encounters. So the carrier encounter file includes both a claim level component and a line level component. And so the claim level component is sort of the header summarized information. And then the line level component is a service level file that lists all the services that were received by a given beneficiary. So for this analysis, we used the line level files. And there were two key fields that we used on each of the line level files. So the first was the HCPCS code. So this is the Healthcare Commons Procedure Coding System code. And so what it does is identifies the relevant services that we need to identify from the HEDIS specifications for outpatient visits and ED visits. And then the second field that we used was the place of service code. So this indicates where a given service was provided. So was it in an office or an outpatient hospital department or emergency department? Okay, and then the third file we used was the outpatient encounter files. So the outpatient encounter files include records for outpatient facility providers. So be it a hospital outpatient department, an emergency department, a ambulatory surgery center, et cetera. And so what we use these files because the HEDIS specifications for both outpatient and ED visits are also identified in part using facility records. And so just to review, the outpatient files include both claim level and revenue center information. And so again, the claim level is like the summarized information for the claim, and then the revenue center level information lists the services that are that were used during this episode of care. And so for this analysis, we use the revenue center files. And the key fields that we used were, again, similar to the carrier file. We identified services using the HCPCS code on a given revenue center line. And then we used the revenue center codes, which indicated which part of a facility provided a given service. And specifically, was it, did this service occur in an emergency department? I'm just going to pause and ask if anyone has any questions.
Some people are wondering about the availability of HEDIS data.
About the what?
The availability of HEDIS data. And
yeah.
So maybe I felt like maybe you're more knowledgeable than I am and could talk about it. I did send a link to some PUF files on the CMS website. But maybe
no, I would be happy to.
And also, one person specifically asked about if we can share the HEDIS specifications for these two measures, and I think the answer is no, but maybe you can talk about that. Maybe I'm wrong there.
Yeah, no, it's both are great questions. So obtaining, so I've worked with the HEDIS person level data in the past, and so to get the person level data, you go through a similar process as the process to obtain other CMS data, in the sense that you submit your requests to ResDAC and you indicate the years of HEDIS data that you are requesting, but it actually gets reviewed by a different part of CMS. So there's sort of a different office. I mean, I think it's incorporated in the general data request DUA process, but it also goes through this other office which collects the HEDIS data. So it's a little different than, obtaining the encounter data. I guess that's I don't know if that totally answers the question, but that's how that works. And then actually what happens in the end is that they send you the data separately from, it's not part of the same package that you get from CCW for the rest of your Medicare data files. And then in terms of the specifications, in fact, in order to get the specifications, you actually have to buy a license that you can't share. So unfortunately, we're not able to share these specifications just as a part of our agreement, our license agreement. So apologies for that. Are there any other questions? Okay. I would say, I think that you can kind of get at, if you search the internet, I think there are places you can find specifications for some of these measures. So, I'm not, off the top of my head, I'm not exactly sure where. Okay. Okay, so I'm going to just discuss how we identified outpatient visits and ED visits in the encounter data to replicate the HEDIS specifications. So, our first measure for outpatient visits, our first method was to start by just identifying lines in the carrier file that had a HCPCS or CPT code that indicated an outpatient visit. So there's sort of a range of lines that are considered outpatient visits by NCQA. So that's the first approach to identify these lines. Excuse me. The second, excuse me. I'm getting over COVID. I'm negative, but I just have this post-COVID cough, so please excuse that. So the second and third method, you identify the carrier lines that have a outpatient visit, and you identify outpatient file lines that have appropriate revenue codes that indicate that a given service was provided in a clinic. And so then for all these methods, what you do is we've identified these service lines based on and then we basically want to not double count visits. So we performed a deduplication of the service lines based on the beneficiary ID, the from date on the service, the through date on the service, and then the provider of the service, which is based on the MPI. And so the idea here is basically, we just want to count one outpatient visit for the same person seeing the same doctor on the same day. And then the difference between our second and third method is whether or not we counted, if you saw one provider on the carrier professional claim and a different provider on the outpatient claim. In method 2, we considered those the same visit, and in method 3, we consider those separate visits. And then as a part of this definition, we excluded people who are using hospice and individuals using either mental health or chemical dependency services. Any questions on the identification of outpatient visits? Okay. And then this is how we identified emergency department visits. So it's sort of a similar process. So our first method was just using the outpatient encounter file, and we identified emergency department revenue center codes. And so, like you'd expect, if a service was provided in an emergency department, then that is indicating an ED visit. And then in our methods 2 and 3, we also considered carrier lines where, like, either a procedure was provided that is only provided in an emergency department, or an emergency department place of service was listed. And so, I mean, the general idea here is just that, method 1, just use the outpatient file. Methods 2 and 3 use both the outpatient file and the carrier file. And they were just, methods 2 and 3 were just like a little bit stricter about which carrier ER records we included. And here too, we performed a deduplication where basically, if we saw a given beneficiary with the overlapping, or we saw services received by the same beneficiary with the same from date and through date, or the from date and through date were overlapping, we just considered it one ED visit. And then we excluded, again, hospice users, users of mental health services, or individuals who were subsequently admitted to an inpatient facility or a skilled nursing facility. This is actually something that's maybe worth noting. Like in the fee-for-service data, if you see, excuse me, if you see on the outpatient file that someone was admitted to an emergency department, typically that means they weren't then admitted to an inpatient facility, because the way it works in fee-for-service Medicare is that all gets wrapped into the inpatient stay. There's not a separate payment to the emergency department, but that is not always the case for Medicare Advantage plans. So, so when you're working with, if you want to get ED visits that were not admitted to the inpatient ward, then you need to actually find the inpatient claims and confirm that there wasn't an inpatient stay that occurred after the ED visit. Are there any questions about identifying ED visits? Okay.
I was just curious why you used folks going to SNF to exclude people as well as hospitals.
So this was just to conform with the HEDIS specifications.
So that was spelled out in HEDIS.
Yes.
Fascinating.
Is that Becky? Correct me if I'm wrong on that.
No, that's correct.
Yeah. So yeah, I mean, our goal here, and I should just note that like that, I mean, HEDIS provides the specifications are pretty detailed, but they're sometimes it's a little unclear whether you should treat two statements as ands or ors, and then the other question is like, how does the health plan interpret
yes.
these specifications? And so our goal was just to try to be like, take like a really obvious, easy approach, and then take a broader approach and just see how much it, how much it affected the results.
Health users, that was also in the HEDIS spec?
I believe so. That's right.
There were listings of diagnosis and procedure codes that we use to exclude mental health.
So anybody with a history of mental health use?
No, it was just like on the actual encounter for the ED visit had to be on there. Yeah.
So that the visit itself did not appear to have a mental health component to it.
Correct.
Yes.
Okay. Gotcha. That's different. Yep. Gotcha. Thanks.
Becky, I have a question. As far as I know, the HEDIS specifications do not say whether or not to include or exclude chart reviews. What was your thinking about not including the chart reviews when your analysis shows that sometimes there's additional diagnoses that should be added?
That's a good question. I think it was just a decision that we made. I don't know, Peter. I mean,
I don't think we use diagnosis codes though.
Well, to identify, like, say, these mental health claims, there are diagnosis codes specified in HEDIS.
Oh, I see.
So
okay.
We would have missed those, but if they had been added by chart review. But I would not expect that to have made a drastic difference in our results. Sure.
Yeah, it gets down to also how that level of specificity is sort of not included in the specifications. So how would the plans think about that? But it is something, in our least conservative approach, we could incorporate those measures. So
yeah, I would say that I have tried a very similar analysis looking at other HEDIS measures, and we're wondering whether or not we should be including the chart review records on these heavily diagnosis-based HEDIS measures, because is that the congruence of what you're calling here gold standard, which is what we're using as well. The HEDIS, we're using HEDIS patient level data. Yeah, we're just trying to match it better, and we've been kind of scratching our heads. What else are we missing? And I think the only piece for us is the chart review. So curious for what you guys did too here. So thank you.
Yeah. I mean, I think I'm sure in these more diagnosis-based HEDIS measures, like that's a really key question. And I think, I might try it both ways if I were in that position, I think.
As I recall, I don't think plans are allowed to utilize additional diagnoses derived from chart review or the data they submit to NCQA for determining HEDIS compliance.
Really?
They are allowed to do chart review for certain measures, but you are restricted to specific items of information that are permissible to take off of the chart. And I wouldn't swear to it, but my recollection is that you can't infer diagnosis that way. You can infer events, for example, office visits and so on. But I don't believe you can add diagnosis. But I'm not certain of that. But.
Yeah, I think this is something we'll follow up on and see if we can get any guidance on this. So feel free to follow up after the workshop today, and we'll try to get an answer to this question.
Thank you.
Thanks, Julie and Chris. Okay, so I mean, just to be just really clear about how we constructed the encounter-based contract level visit rates. So our numerator was we'd found these outpatient or ED visits that we had then deduplicated. And so we essentially are summing up the number of outpatient or ED visits for a given contract and contract C and year T. And then the denominator is the total number of member months for that contract C and year T. And then we're just multiplying that by 1,000. And so, once we have this measure, this is where we're going to compare that encounter-based visit rate, which is now at the contract year level, to the HEDIS-based visit rates. And we're going to do this, which are already at the contract year level. And so we're going to just look at the ratio of the encounter-based rates to the HEDIS-based rates. And we'll do this separately for the outpatient and ED visit measures. And then the way to interpret this ratio is that a higher ratio means that the encounter data is capturing more visits than the HEDIS data, and a lower ratio means that the encounter data is capturing fewer visits than HEDIS. Okay, and then we're gonna look at a few different analyses. So we're gonna compare the ratios across these different methods for identifying outpatient and ED visits. We're gonna look at whether these ratios changed over time. So the question being, are the encounter data becoming more complete since 2015? We're going to focus on the 5 largest insurers between 2015 and 2018. So these are capturing 62% of Medicare Advantage enrollment. The idea being that maybe size contributes to the ability to submit these comprehensively. And then finally, we examined Medicare Advantage organizations that were either high or low outliers in 2018 in terms of completeness. So just to start, we're looking here at the encounter to HEDIS ratios in 2018 for ambulatory outpatient visits. And so the first row is for method 1, which is just using the carrier file to identify outpatient visits. And so the median contract using method 1, the ratio was 0.942. So basically, we're capturing, something like 6% fewer visits we have a 6% lower visit rate in the encounter data than we do in the HEDIS data for the median contract. But that really varies a lot. So, when we're looking at the 95% interval here, the 2.5th percentile contract is below 60.6, and then at the high end we have a ratio of 1.2. So it does vary quite a bit across contracts. And then our preferred, as we add in the outpatient files in method 2 and method 3, we capture more outpatient visits. And so our preferred approach is that we're going to look at in more detail is method 3, which uses the carrier and the outpatient files and has a less strict deduplication. And so in that case, our ratio is 1.023, which indicates that we're actually capturing, for the median contract, we're capturing a slightly higher number of visits than is in the HEDIS data. And then the 95% interval here, the low end, the 2.5 percentile, it's a 0.81, and then at the 97.5 percentile, it's the ratio is 1.3. So then we looked at using that method 3. How did these ratios change over time? And so what we plot here is the encounter to HEDIS ratio over time by the percentile across contracts. So the top line here is for the 97.5th percentile, and then this is for the 2.5 percentile, the kind of dotted line. The solid line is the median, and then these two dashed lines indicate the 25th and 75th percentile. So this is kind of the interquartile range across contracts in a given year. And so I think the key takeaway here is that actually the median contract doesn't change that much between 2015 and 2018 in our data. So it's like slightly more than 1 over this entire period. Another key takeaway is that the interquartile range doesn't change that much. And also, the interquartile range, like the median, sort of indicates like pretty good concordance between the encounter data and the HEDIS data. So, the 25th percentile is 0.999, and the 75th percentile is like 1.07. So actually, we're getting kind of similar answers in terms of outpatient visits for those contracts between the encounter data and the HEDIS data. But we also do have some kind of outliers. So, especially in 2015, where there's really, quite a few more visits in the outpatient data, or quite a bit fewer visits in the encounter data. So these outliers are of some concern. The other thing is that the outliers, the tails do converge a little bit in 2018. So then next we look at the same ratios for the top 5 largest Medicare Advantage insurers. And again, we're using this method 3, using both the carrier and the outpatient encounter files. And actually, it's a pretty similar story when we're looking, comparing, looking at the top 5 insurers compared to to all contracts. So, pretty good concordance for sort of that interquartile range of contracts, but definitely have some outliers on the positive side, on the at the top and the bottom of the range. And then just looking for outpatient visits at the sort of the largest Medicare Advantage organizations in 2018. It's and so this first column plots or displays the encounter to HEDIS ratio for the median contract, and then the second column shows this range between the 2.5 and 97.5th percentile. And what you see is that there is overall the largest Medicare Advantage organizations have pretty good concordance between the encounter and the HEDIS data. So United Health Group is at the top end here with 1.08. Humana is at 1.01. Anthem's at 1 point. It's just over 1. But actually Kaiser is a little bit low. So this implies that Kaiser is actually submitting more visits through HEDIS than they are through the encounter data. And we don't really fully understand why that's the case, but it is quite a bit lower. And so then I'll move on to ED visits unless there are any questions. Okay, so this table displays our encounter to HEDIS ratios using the 3 methods. So this column again shows the median contract, and again, when we use our first method that just uses the outpatient encounter file, we capture slightly fewer ED visits in the encounter data compared to HEDIS. But then when we use our most inclusive method 3, using the carrier and the outpatient files, we capture slightly more visits using the encounter data. And then then our range here, at the top of the distribution where it's capturing 38% higher visits in the encounter data, and then at the bottom of the distribution the ratio is only 0.8. When we look at the ratio over time, again, we find pretty good concordance for the median contract even in 2015, and that continues over the entire sample period. The interquartile range is also pretty constant over this period. So it's ranging, the 25th percentile is 0.963 and the 75th percentile is 1.064. But again, similar to the outpatient visits, we do have some outliers at the top and the bottom of the distribution. So 1.4 at the top in 2018 and 0.8 again in 2018 for the bottom. And then looking at the top 5 Medicare Advantage insurers, actually it's a similar pattern, but the outliers are less pronounced. So this is only 1.2 in 2018, where it was 1.4 if we looked at all of the insurers here. So the outlier problem is not quite as pronounced. And then finally, looking at the ratios by Medicare Advantage organization, looking at the top 5 organizations. So again, we generally have pretty good concordance between the encounter data and the HEDIS data for like the median contract. Actually, Kaiser here is actually a little higher, where it was lower for the outpatient visits. Aetna is a little bit lower here, so the ratio being 0.92. But what I would actually mention here is just that for the for these top 5 insurers, like the variation across contracts within an insurer is a bit more narrow than you find when you're looking across like all contracts in a given year. Okay. So just to summarize, I would describe our findings as that we're finding sort of medium concordance between HEDIS and encounter-based outpatient and ED visit rates across contracts. So, the median contract is showing pretty good concordance, and then 50%, I guess this should say 50% of contracts, the ratio is, within plus or minus 6% of one. So it's like there's not a lot of discordance, but there definitely are some contracts with less concordance where you find like a 20 to 40% difference in the encounter versus the HEDIS data, although these outliers have improved somewhat over time. And I think these contracts where there isn't concordance, like this could be reflecting that there are different interpretations of HEDIS specifications across plans. One thing is that this could be driven by smaller contracts, and that's maybe something we should incorporate into our future analyses. So that could introduce some noise into this analysis. But generally, I think our results are pretty consistent with some of the work that Jia Zhang has published recently. I think she uses slightly different methodology, but I think our results are pretty similar. And I think the key takeaway as a user of Medicare Advantage data, encounter data, is that, excuse me, these public HEDIS files, I think, are a useful gauge for determining whether contracts are complete. So especially if you're doing an analysis that focuses on a specific insurer or a specific set of contracts, this is a good way to sort of say, like for the ED visits or the outpatient visits, how much correspondence is there between what plans are submitting for HEDIS and what's in the encounter data. And that might guide your decisions about which contracts or plans you include in your analysis. And the nice thing is that even if you don't have the person level data, you can still do this at the contract level. And you can just download the public data from the CMS website. So there are a few references on the slides that you can use for future reading or for further reading. So are there any questions?
I think Becky's been doing a great job of answering questions within the chat. If there's anything that we've missed, though, please feel free to ask again.
So do the references list which contracts with low concordance outside of the top 5? They do not. So the idea is,
yeah, I guess I was trying to think if I wanted to do a study and I wanted to exclude contracts that were less complete, how would I go about doing that?
Yeah, I think what I would do is, I guess it's, I think I would maybe repeat, I guess, I don't know. I might actually repeat the analysis that we did here, because I think if you're already working with the carrier data and the outpatient data, like if you're doing some kind of analysis of numbers of outpatient visits and ED visits, it's not too bad to create some contract level counts, and you can just look at a contract to contract basis, like how well these align. So I guess that was my thought. But I mean, I guess I'd be curious what Becky and staff think about that.
Well, if I'm maybe I'm not understanding, but so you can evaluate any contract you want. You just need to pull pull the data from Encounter by referencing the there are contract numbers on the Encounter data themselves. So you could pull it from the MBSF for members if you wanted to double check it, what's in the Encounter data. But I'm sorry, maybe I don't quite understand the question. Are you wondering how to know which contracts may be low, reporting in a low manner?
Yeah, I was just like, given that this work has already been done, if I were doing a study that was specifically focused on ambulatory outpatient visits or ED visits, would there be a way to, use something that's already been published on which contracts tend to have lower concordance with HEDIS?
Well, we haven't published anything yet. So might be something you could work on. Yeah, I don't know that we would publish that level of detail. I'm not sure. Maybe it's still something we're looking into.
I was just double checking. I think I can't remember if Gia's article actually does do a little bit of that. Let's see. She does provide, yeah, so she does have a list, a supplement to her 2022 article, listing plans with high completeness. I don't think that she has done the corollary of listing plans with low completeness, but I just wanted to say that that is out there. So yeah, you can take a look at that if you'd like.